We've had actually two big themes at this conference, and the prevention theme has probably had its perhaps most focus at this conference more than any in recent years. We've known for some time that we can give people who are HIV negative either one or two antivirals to protect themselves from acquiring HIV. We had the pivotal study called IPREX, as well as the Caprica study presented last summer to tell us that tenofovir or tenofovir plus FTC can help people who don't have HIV to protect themselves if they are sexually active in a manner that puts them at risk. At this conference, we saw two more studies looking at the issue of both tenofovir orally as well as tenofovir plus FTC in that same setting, and in very large studies, once again, people are clearly protected as a result of taking tenofovir or tenofovir FTC, or protected from acquiring HIV infection. We have no good news on a vaccine still, and so right now, treatment of people who are negative with these antivirals remains one of the key biologic approaches to prevention. We also saw at this conference the recently announced study for the impact of treating people with HIV and the impact of that on transmission. We saw the dramatic data showing that essentially, with one exception, that people who are well treated, whose virus is suppressed, had extremely low risk of transmitting to their partner. Indeed, there was only one transmission in this entire study of somebody on antivirals. That transmission happened in the first month of this person taking their antivirals, is when the transmission occurred. And so that certainly is certainly a very dramatic outcome. We should point out that that study was done in a roughly 95% heterosexual couple setting. And while the biology makes sense to presume that it would certainly apply to other kind of men who have sex with men, for example, and other exposures, we can't be as certain as we'd perhaps want to be. So that I think there's still a couple of question marks of how that study applies to every population. And the reason I think we can have that little bit of a question mark is because in the work of prevention, taking again an antiviral to protect ourselves, we have the very significant findings in men who have sex with men, and we have one negative study that was done in a heterosexual study in which women were not protected when they took the same antivirals. And we here at this study did see positive studies in women, and we have one negative study. And so there's still some uncertainty in this field about the role of treatment as prevention and how we generalize this. Nevertheless, there's no doubt we can dramatically start to contain this epidemic in addition to all the work we do on safe sex counseling and prevention, condom promotion. We now have this biologic approach. So that's that story. The treatment story here at this conference has a lot to say as well. In terms of starting therapy, we continue to have lots of discussions about what could be the beneficial impact of starting therapy earlier. We continue to look at data that supports starting earlier might help people do better, given that our antivirals are pretty safe. We also continue to see that there are question marks in how certain we can be about what is that benefit. Is there, in fact, going to be as much benefit as we want there to be? And is the net benefit worth it in somebody who has high CD4s, given that our medicines continue to have toxicities that we learn about at each and every conference? So the START trial, which is the randomized answer to that question, is well underway with about 1,500 people randomized internationally, and perhaps in the next 3 to 4 years, it would have an answer to that question if it's fully enrolled. So there's a lot of enthusiasm to, I think, answer that question, because we continue to learn things that kind of encourage us to want to stop this virus with the best tools we have to stop the damage it does as early as we can do it. But we're not sure just how much we do prevent and stop that damage. So that's why that study feels very important right now. If we move from that question to kind of which medicines are best, at this conference we continue to have information to support that our top 4 combinations, at least in the US guidelines, continue to have excellent outcomes. We've seen long-term data on those combinations that continues to support them. In terms of new drugs, we have a couple of front runners. Rilpivirine was recently approved. We presented here the 2-year data on rilpivirine, showing that rilpivirine performs at least as well as efavirenz, particularly in those people whose viral load is below 100,000 when they start. In people whose viral load is above 100,000, there certainly does appear to be an increased risk of virologic failure. And so this drug is looking particularly important as an option for people whose viral load is on the lower half rather than the higher half. Though there are people certainly with high viral loads who do quite well on rilpivirine, I think it's fair to say that the field is learning from that study. In addition, at year 2, we don't see any new toxicities on rilpivirine. The drug continues to look actually very well tolerated. So the initial story of it being an easier to tolerate drug than efavirenz continues to be true at year 2. We also saw some pretty exciting data on some new drugs like dolutegravir, the next integrase inhibitor, in its phase 2 trial, continuing to look really quite excellent in the field. At this conference, we continue to see that data. We also learned that elvitegravir, the integrase inhibitor being developed by Gilead, is at least as potent as raltegravir in suppressing the virus in treatment-experienced patients. So we've got good news on our pipeline on those drugs. We did see another non-nucleoside study of a drug that's called lurcivirine, and this is a drug being developed by ViiV. And its efficacy was probably okay, though there was a little bit of a question mark because some patients with high viral loads didn't do as well, and the author explained that as possibly being an adherence concern. And that may be true, but it certainly raises a question mark for the drug. In addition, they showed us that about 40% of patients complained of nausea on that drug, and they didn't give us enough detail to know if that's temporary the first month or all year long. And so I think we're going to need a little more information to know exactly where this drug belongs and fits. Nevertheless, it's always encouraging to see that companies continue to look for a pipeline. So I think that we've got continued good news in prevention, continued good news on treatment. The treatments we have work. They work so well that we are enthusiastic about the possibility of treating anyone with HIV infection, both to protect a partner as well as to protect themselves.